I think we are beginning to enter a new phase in pain medicine as a specialty, and I guess in many ways I'm not sure if we should call it pain medicine anymore going forward, but that's the origin of the field. In fact, the origin of the field is interventional, going back decades with Dr. Bonica in Washington, where it sort of started in the recovery rooms, where we used to do interventions. So that's even before my time, but I think going forward, I find that we're beginning to cross over into some of the surgical specialties. It's becoming a surgical subspecialty in many ways, but it's not just focused on the spine or on the periphery, it's really both. And I think that's unique, that's an opportunity, and that's not the only thing that we do. I think we've got to keep in mind the whole patient and be a neurologist, a rheumatologist, an orthopedist, and internist at the same time. So build on our strengths and be multidisciplinary in one discipline as much as possible. But the interventional aspect is certainly crossing over into neurosurgery, spine, and orthopedics. The peripheral ablative techniques, the peripheral stimulation, cryo of the shoulder and the knee. I do think we're pushing the open surgery approach further sort of downstream in the treatment spectrum because of the efficacy and good data behind the interventions. I must say we don't have an alternative yet that I've heard. I've felt that pain has always had a negative connotation. It used to be worse. It used to be called pain management, as if we're some manager at a department store type of a thing. But I think pain medicine is a step in the right direction. And I think it's sort of more encompassing, thinking it could be neuropathic, psychological, structural, and so on. But I think in the current climate, pain medicine physicians do have some negative perception by the public and by other specialists. Although we haven't over-prescribed opioids, I think we've been very reasonable in prescribing opioids. We're still pain specialists, and we sort of get bunched up with the clinicians that have over-prescribed. So that's unfortunate, and therefore we get a lot of referrals of patients that are inappropriately treated, that are now addicted, that are not being sent to a pain specialist. Well, they don't need a pain specialist. They need a detox center, they need an addictionologist. And it's very tough to mitigate that and stop that without upsetting the referrer as well as the patient. Do I think the problem is going to go away? I don't think so. I think it's sort of here to stay for quite some time. I mean, I look to discussing this further with my colleagues as far as if we can rename the specialty, which is going to be quite difficult at this point. It's just so imprinted into our board certification, into the American Society of Anesthesiology, nomenclature, and into other specialties from physical medicine, rehab, and neurology. They also use the same pain terminology: pain specialist, pain certification, subspecialty certification, and pain management or pain medicine. So I'm not sure if it's going to happen, if you're going to be able to rename the specialty. But I think we can certainly rename the practice and take out the word pain.